from West Coast, East Coast of the United States. We like to bring this conversation to the forefront every single week. We have tens of thousands of users on the FertilityAnswers app platform. They ask a lot of questions, and sometimes it really helps to hear straight from an IVF doctor's mouth the ability to kind of break things down into bite-sized chunks such that you're empowered to have the right conversation with your doctor or your specialist. And today's topic is one that's been kind of weighing on my heart a lot, Serena, because time and time again, we're seeing in the feed women coming to us with, my doctor thinks maybe I have PCOS, maybe I have endo, maybe I have this, or they've looked at everything and it all seems fine, but we know it's not fine because we know they're not conceiving. And I get frustrated over this lack of kind of a proper diagnosis. And I feel like the patients are kind of left with, well, I guess that's how it's supposed to be, rather than the approach of, when they've got a symptom and we're going to break down the symptoms, knowing what to ask their doctor to do.
Okay.
So let's first kind of break down the environment that they're in terms of how many minutes does a standard OBGYN or primary care or family doctor get with their patient, in their annual visit per year. Do we know an average length of time that visit is?
I think it's really just a few minutes of talking, where you really don't have a lot of time to ask questions, and things like PCOS and those types of things are, they take time, they're detailed, they're complicated, they involve it, in order to manage them properly, requires really a multi-pronged approach, not just medical, but also lifestyle approaches. And our medical care system is not really set up for that. That's why a lot of times on the MedAnswers app, I'll tell people, okay, that's what your GYN said, but I think you're right. You might have PCOS or you might have endometriosis. And you're right. We see this all the time, every day on the app. And I feel like sometimes I sound like a broken record, but I am often telling people, I think maybe you need to see a reproductive endocrinologist. You need to see somebody whose job it is to sort those things out, because this is a gynecologic issue, but your OBGYN may not have time to do this. Now, to be fair to the OBGYN, the annual visit is not designed to figure this out. So to wait an entire year, save up an hour's worth of questions, and then dump it on your OBGYN when they're supposed to do your PAP and get you out the door, you're not using it correctly. I think you have to get your annual visit. You have to do your pap smear. And I know you're busy, but your health is important and you have a lot of questions. I think you should say, Dr. Smith, I really want to discuss these things with you. What's the best way to address that? Should I make an appointment in a couple of weeks? Should I see you next month? What kind of appointment should I ask for? And some doctors will actually say, oh, we can talk about it on the phone, or you might email me, or the doctor will say, I should see you next week. And I know some doctors, I think, who, have a couple friends who take care of very complicated patients that are primary care physicians, and they're very considerate about this. And they'll say to their patient, I want to address all these things. I cannot spend all this time to really address this today. Tell me what's bothering you the most today, and then let's make a follow-up visit to address these other things.
Got it. Okay. That makes a lot of sense. So even educating the market to say your annual visit is for very specific wellness things, your pap smear, your breast your physician exam, not your self-exam, but your physician exam. Yeah, it's for those types of things.
Basic boxes. Yeah. It's not. It's not a problem visit. It's
not a problem visit, right? Yeah. So schedule a separate problem visit.
Sometimes you're, especially if your doctor's in a very rigid healthcare system, you may be putting them in an awkward position where they're doing things for you that they can't bill for, and that's not good for their numbers. It just can create issues. So
okay, got it. Now let's dive into something really specifically that does happen all the time is patients coming to us saying it might be PCOS, it might be endo. I didn't think those two had similar enough symptoms for somebody to actually not be going down one or the other. And then it's really devastating when people come on the app and say, I've been diagnosed with both. And I just think, gosh, that sounds incredibly
So
unfair.
you're right. I think the classic forms of these diseases don't have any overlap. But the thing is that PCOS affects at least 10% of the population.
It's a lot.
Overweight and obesity can affect up to 2/3, especially of infertility patients. And a lot of obesity symptoms can look like PCOS. And because we don't really have a way to diagnose PCOS,
Sure.
sometimes it's hard to tell. And then meanwhile, the prevalence of endometriosis in the general population is also quite high, but in the infertility population, the prevalence of endometriosis is like probably way over 50%. Now,
Over
endometriosis
50
can
or
go
15?
50,
50.
50%, really super high, super high. But
Wow, I had no idea.
a lot of the endo is not the symptomatic type endo that
Okay.
I'm talking about. If we did a laparoscopy on every single infertility patient, we could find a very high percentage of
Sure.
unexplained infertility with zero
Okay.
symptoms,
Wow.
completely normal periods, not painful periods, having stage 1 or 2 endometriosis. So there's a lot of endometriosis in the
Wow.
infertility population in general. And we are often not definitively diagnosing it because putting a hole in somebody's belly button doesn't really help them get pregnant. And then you end up with a hole in your belly button, like, what did you
Right.
do that for? So I am often telling my patients, I'm sorry that
Mm-hmm.
I cannot, um, that I cannot give you a diagnosis, but I do feel like I have a very good chance of getting you a baby. So I know that the lack of diagnostic precision can be difficult, but sometimes that's okay. But you're talking about people who have like symptoms, right?
Yeah, but
Like irregular
well, people
periods.
who are, yeah, I mean, people who are struggling to conceive and they're going to their OBGYN trying to find out what's the root of the cause and what they can do about it, right? So let's backtrack for a second to something really important that you said that I think the world needs to understand. And that is the lack of uh kind of a slam dunk with diagnosing PCOS. We don't have a singular blood test. We don't have a singular visual test. We don't have a surgical confirmation test. Talk to us about that pathway of how providers are diagnosing PCOS so that everybody understands that there's not a great way.
PCOS is a clinical diagnosis. It's a clinical diagnosis. So you're putting together the number one symptom is irregular periods. So anybody who has irregular periods, we need to make sure they're not pregnant. We need to make sure their prolactin hormone level is normal and that their thyroid is normal and that there's no other crazy things going on, and then most likely they have PCOS. That's how common PCOS is. So
Wow.
it's like the number one diagnosis for irregular
So you don't
periods.
even have to
Other
have any cysts at all to get a diagnosis of
Yeah, the
PCOS.
whole cyst thing is kind of a misnomer. There's no real cysts in PCOS. It's called polycystic ovarian syndrome in from the 1920s when Stein and Leventhal first did surgery on these ovaries, and they saw these really big fat ovaries with tons of little tiny follicles, and they thought they
Hmm.
were cysts, and they're not technically cysts. They're really just
They're follicles.
follicles. But cyst
Got
in
it.
this context is being used for any like little fluid
Hmm.
filled circles in your ovary.
I see. And in the case of what we've seen with labs, a lot of women with PCOS have higher levels of AMH because those little follicles secrete AMH. Therefore, if they have more follicles than their peer, they would have higher levels of
You
AMH.
know,
Is that correct?
I guess that's right. I guess I should know more about that, but like I feel like yes, we do definitely see um, higher AMH levels, but remember that PCOS can also exist in the context of menopause. that the
Right.
metabolic issues that PCOS women experience seem to continue through menopause, and that's when they have no cysts and they have
Right.
no AMH.
Right.
So we can't
So it's not
completely,
an ovary thing, right? To
yeah,
blame it on the ovaries doesn't make any sense when it does continue
right.
into menopause. Yeah,
It
which
seems to be a brain issue that a
got it.
brain insulin receptor issue that is genetically based. So we're
Yeah,
honestly not totally sure what the primary defect
right.
is. I think a lot of people do feel like the culprit might be the insulin receptor, but I'm not sure that we can say definitively yet.
I mean, our company hopes to participate in some research next year around this particular topic because this is so frustrating and it would allow, I mean, so many treatment options would open up, so many lifestyle choices could open up if
Absolutely.
people know really what's at the root
Yes.
of this. We often don't know. We do see, and we have a wonderful, doctor that that's one of our investors in the company in Singapore. And she says, well, my PCOS patients are all very thin and they have very low vitamin D
Yeah.
levels.
And
And in the
that's
US,
typical for the Asian population, and they don't have the extra hair growth on the face.
right.
Um, but they do often have acne, so it can be a very different population. And Alice, it's possible that we're talking about a group of diseases, that there may be more
Mm-hmm.
than one cause for what we're calling polycystic ovarian syndrome. And so, but I think the big thing is anybody with irregular periods, we need to think about polycystic ovarian syndrome. There, there, a lot of reproductive endocrinologists believe there's a group of people who have regular cycles who also have some PCOS like characteristics. That's much harder to figure out. But if somebody has irregular periods, like if their periods are more than 35 days apart from the first day of bleeding to the next first day of bleeding, then typically the most likely diagnosis is often PCOS, although you have to look at thyroid, prolactin, and pregnancy, because pregnancy can cause irregular bleeding. Now, PCOS, when it first starts, has these cycles that are far apart. And then if you don't get treated and you don't address that, a lot of PCOS patients turn into bleeders where they're just bleeding heavily all the time. And I worry about those patients because that often means after years of not getting their period and then suddenly having heavy bleeding, that they're heading into the cancer zone. And that's one of we're not into periods per se, but we
Yeah,
are looking at periods as a possible marker of like just general health.
sure, sure. Got it. Okay. And also heavy bleeders could indicate maybe fibroids too, right?
Yes.
So yeah, all of these things are concerning. Now, talk to me more about endometriosis. Symptoms. I always associated, the painful periods and the crippling pain with endometriosis. Are there other symptoms, though? It seems that there's
Well,
other
one of the
symptoms than
top
celiac.
symptoms, one of the number one symptoms with endometriosis seems to be infertility, although I'm not sure that we have true population data on that, because you'd
Mhm.
have to like just do a scope on every single
Sure.
person for no reason and see what the prevalence is of endometriosis. We know that, again, if you were to do a laparoscopy on everybody with unexplained infertility, you would see this very high rate of minimal to mild endometriosis, which can be a significant cause for infertility. So endometriosis, we think is actually quite common. I wonder if it seems to become more common the longer you delay childbearing.
Mm.
Um, we also wonder with like estrogen, um, more estrogen exposure, is it possible that that's increasing the risk for endometriosis? Like, what about these endocrine disruptors? What about obesity? Is it possible that those are positively associated with more endometriosis? Delayed childbearing, we think, is associated with endometriosis. There's a lot of things we don't know. There's so much research that needs to be done in this area, and it's definitely an underfunded area.
Right.
Um, and it's classically surgically diagnosed. So a lot of people that have endometriosis don't really know that they have it. But a lot of people with very painful periods heavy periods, bleeding between periods,
Mm,
and cyst on their ovaries, painful sex, uh,
wow.
backwards tilted uteruses. Those are some of the kind of classic endometriosis complaints and issues. I often detect moderate to severe endometriosis, stage 3 and stage 4 endometriosis, when I do the pelvic sonogram, because you can often see like a chunk of endometriosis in the
Mm.
ovary. But there are a lot of people that don't get a definitive diagnosis because you just can't see it, but it's there.
And you don't see it if it's in the ovary. Do you see it grow during an ovarian stimulation cycle because of the
Sometimes
extra
you can,
hormones?
sometimes it will, sometimes it won't. It's different, but we tend to feel like endometriosis seems to get worse with bleeding and periods, which is why birth control pills tend to delay onset of severe endometriosis, and can
I see.
be, there's no cure for endometriosis right now, but certainly can help with symptoms and kind of suppression of endometriosis. Because you can even see under the microscope endometriosis, um, they look like it looks like under the microscope like the glands and supporting stroma that you see in the lining of the uterus, which is called the endometrium, which is where endometriosis gets its name. And when you give birth control pills or progesterone or Lupron or Lissa, one of these drugs that suppresses endometriosis, you can see the cells just like kind of shriveling up and shrinking
Oh,
down. So
wow.
that's why
Okay.
sometimes people can get years of remission after one of these treatments and after
You,
pregnancy.
that's amazing. Okay. So in your perspective, you're saying, yes, you might have endometriosis. I'm still going to help you have a baby the same way. Therefore, what's the priority? Do you want to go ahead and proceed with, a surgical diagnosis of endometriosis, or do you want to proceed with
Yeah.
IVF?
So
Correct?
if somebody doesn't have any signs of stage 3 or stage 4 endometriosis, they are often treated exactly the same as somebody with unexplained infertility, as long as the tubes are open and the sperm looks okay. And the data shows that that's a reasonable way to approach stage 1 and stage 2 endometriosis. And it definitely works much better than say surgery. So there, like a while ago, there was a big Canadian study that took a bunch of patients, and um, half of them did did like they what did they do? They did laparoscopy on everybody with unexplained infertility, and the ones that had endometriosis, they I think buzzed the endometriosis. Half of them they buzzed the endometriosis, half of them they didn't. The ones where they lasered the endometriosis had a bump in their pregnancy rate from the order of like, instead of like a pregnancy rate of 1 or 2% per month, they went up to 2 or 3% per month. So they definitely got a measurable, statistically significant increase in their pregnancy rate from the laser surgical
Got it.
treatment of their endometriosis. But if you just give somebody Clomid and IUI, you're bumping their pregnancy rate up to maybe like 10-15%.
Right.
And it's much
Right.
easier and safer and less painful than doing
Sure.
a surgery. So
Right.
what
Right.
we have is like,
You can
well,
replace endo with scar tissue after you do a surgery.
exactly. So we treat we don't feel that from a medical perspective it's beneficial to get a definitive diagnosis of stage 1 or stage 2 endometriosis. Now, if you have stage 3 or stage 4 endometriosis, that's
Yeah.
that's much more controversial. You might need surgery. In general, I tend to be in the camp, and there's definitely multiple camps, and you could get a bunch of doctors on here and none of us would handle it exactly the same way. But I tend to feel like if somebody's trying to get pregnant, I try to avoid doing major surgery on them. I feel like I
Mm-hmm.
should just try to get them pregnant.
Right.
Sometimes that's not possible, but in general, with stage 3 endometriosis, I feel like if I do surgery, they might lose a lot of their eggs, It often
Right.
delays conception time, and the surgery alone usually will not help them conceive. So I usually feel
Mm-hmm.
like if I can safely do IVF and get
Mm-hmm.
them pregnant, that it's better to just get them pregnant than doing surgery. So I am not really in favor of surgery or 6 months of depot Lupron. There have been
Mm-hmm.
studies. I think that some of the most recent analyses have shown that like putting somebody on depot Lupron for 6 months doesn't really seem to do much more than delay their chance at getting some treatment. It doesn't really
Right.
seem to dramatically improve
It's
the
not curative.
pregnancy rate. Yeah.
Sure. Yeah,
Whereas,
definitely not
you
curative.
can go from like a 1% pregnancy rate to 50, 60, 70% pregnancy rate in an endometriosis patient, a severe endometriosis patient with in vitro fertilization, if you can get some eggs.
Wow.
And the surgery might like just destroy a lot of your eggs. So you really have to balance all those considerations.
The
And I
surgery,
think,
but let's break down that risk for a quick second, because I'm visualizing this, I'm a very visual person. So if you're lasering the endometriosis away, especially if it's in the ovaries itself, there's just no way to avoid lasering away some of those follicles, is what I'm hearing.
well,
Or if
the
it's,
endometriosis cysts seem to be pseudocysts. So the endometriosis starts out on the outside of the ovary and then causes
sure.
inflammation and damage. And the ovary tends to get stuck to other organs and wraps
Gosh,
around that stuff. So when they do these things like
that sounds very,
removing the capsule, you're actually removing the whole cortex of the ovary, which
I see.
contains all the eggs.
Right. So when
So
you're saying you could really lose all those eggs, you're removing,
you're literally, yes,
literally removing them.
potentially
Wow.
surgically removing the eggs.
Practically like doing a oophorectomy.
Yeah. So it's
Oh
now
boy.
some people are at high risk for infection and getting really ill from these things or
Sure.
have really debilitating issues. I have a lady right now. She needed to get her endometriomas drained because they were actually blocking the tubes from her kidneys to the bladder. And
Oh
if
my
we let
goodness.
that go, it would have caused kidney damage. Obviously, I can't think about eggs when the
Yeah,
kidneys are at danger.
of course,
So,
of course.
so what
So
I would
each case is
say,
so unique. I mean, but you have to have the visuals to see that. So one thing that I would like to say about specialists too is that your equipment for visualizing inside the body is often superior to the generalized practitioners who are operating in very busy centers. So there is a
yes,
difference in imaging
I
quality.
think reproductive endocrinologists in this country all do a lot of sonograms and are used to seeing these things on a regular basis, whereas a lot of other gynecologists might send to a radiologist and then
Sure,
look at the report later. So
right.
it's a little bit different. There are gynecologists who are very good with this and do a lot of sonograms. It just depends, but it's very consistent with the reproductive endocrinologist. The other thing
Okay.
about surgery is surgery on your ovaries for somebody who wants to get pregnant is a big deal. And if somebody recommends surgery, I would say you should do the same thing you do with any other non-emergent surgery and just, get a second opinion and go to
Absolutely.
resolve.org or post it, call up the MedAnswers people, contact you
Yeah,
guys and just say, hey, can I get a referral for a good specialist
absolutely.
because I'm supposed to get surgery and I want to get a second opinion.
That's right. I mean, they can email navigators at medanswers.com, and we will
Perfect.
have a fertility navigator that can find them somebody that works for them.
Yeah.
And pretty soon we'll be able to match them directly to that kind of specialist anyway.
Well, and
So,
you'll be able to do
and we'll be
teleconsults,
able to do a
right?
telehealth consult, and we'll build in the feature where they can even upload imaging. That's all
Perfect.
coming because we just want to make this as seamless as possible for people to get the right consult at the right time to make these
Yeah.
really important decisions. And, mostly that, yes, it's difficult to diagnose PCOS, but if that is the case, or if endometriosis is the case, there's actually some shared lifestyle changes between the two. And I want to quickly cover that today. Some lifestyle advice changes that you can offer up to, everyone in our community, Serena. What are a few things that they could do that's different whether they have one or the other or, both.
So what's interesting to me now, and I'm not a nutrition expert, but I am finding that a lot of my patients, well, PCOS, we want you to be a healthy weight. So there's that whole weight loss question. But I am finding that this whole more plants, less meat, less carbs, or less sugar, because actually plants have a ton of carbs in them. So getting most of your carbs from plants, avoiding sugar, and having less meat, especially red meat in your diet, like kind of an anti-inflammatory approach to your lifestyle, seems to be really beneficial for both PCOS and endometriosis patients. They're both kind of inflammatory conditions. Endometriosis because there's just a foreign body in your belly, and your body is like on inflammatory, like high alert.
Right.
PCOS because you have this insulin resistance and sugar intolerance, and so that and obesity all creating kind of an inflammatory environment. So there's maybe different pathways to getting to extra inflammation, but we know that a plant-based diet or being more plant-based seems to be helpful in those kinds of conditions and other anti-inflammatory things. People are talking about all kinds of fancy, crazy supplements. Patients come in with these huge bags of supplements, and I'm like, yeah, but
what are you eating?
Plants, sleep, and exercise are the top 3 anti-inflammatory things. It's not glamorous, but before you buy some supplements, you need to exercise. And you need to not just do cardio, you need to do strength. Like, what's all this? I walk all the time. Like, that's great that you walk. It's not enough. You got to sweat a little bit. And women, you have to build your muscles. You don't have testosterone. So you need to work on building your muscles because that really helps you normalize your metabolism.
Right. Hey, Serena, I get night flashes now. Does that count as sweat?
No, it does not.
Wow. But I know. I got to pick it up.
We could do a whole episode on sleep because that's a chronic, it's a chronic problem in the United States is the lack of sleep and so much bad sleep going on.
Good sleep quality. Yeah, we will. We'll do a whole episode on that.
Inflammatory condition that in itself raises inflammation and increases the risk for diabetes and heart disease, and that's one of the best things you can do for yourself is give yourself the gift of like a better sleep routine and better sleep before you buy all those fancy supplements.
Absolutely. We will do a whole show on that, a whole episode, because I'm all about that. Sleep quality is the most important thing. I feel like I'm a walking risk factor right now with my stress level and some sleep quality issues that I'm having anyway. So I'm drinking the Kool-Aid too. This is.
No, I'm guilty also. It's I'm not saying it's easy, but I want people to think about it. I want them to keep it in mind.
Well, and hopefully we have 90% of our user base is coupled up, 90%. So, hopefully we can get people to do this together. It's the end of the year, New Year's resolutions are going to be coming up, and hopefully sort of permanent lifestyle changes. I know people get scared when you say something is forever, but hopefully this is something that becomes core to the relationship, core to the family building practice. Because as we think about what, the energy it takes even to raise your kids, I have a 6-year-old, and it takes more energy getting him off technology right now than it does just jumping on the trampoline with him. So I'd rather be jumping on the trampoline with him.
Exactly.
And we want to be vital enough to be able to do those types of things with our kids.
Yeah, and those things we do for ourselves are going to be gifts that we pass on to our kids. That's as well.
Right. Yeah, they model everything. That's right. They model everything. We want them to love.
Yep.
That's right. We want them to love it. Yeah. So as a takeaway, and on this Motivation Monday, I think this was our longest one. It really warranted going long. We wanted to get nitty gritty, and I think we really did. But the biggest takeaway is that if you are struggling with something, then I think the 3 things that you can ask, 3 things, it's hard to get my visuals in here because the app we use does a mirror image of us. The 3 things though is ask if you have a problem, if you think this might be a problem and I might have PCOS or I might have endometriosis, ask for labs so that you know where all your reproductive hormones are, and you need to know prolactin, thyroid, FSH, LH, estradiol, and AMH, correct? Did I miss anything? Okay.
Progesterone.
And progesterone, yes, and progesterone. And in addition to that, they should visually look at you, visually look at your uterus, visually look at your ovaries. And there are a couple of different types of tests that you can do for that. That you can look inside the uterus. That one's a little bit more painful. Regular sonograms is not painful. I mean, it's discomfort just because, you know, your nice forceps that have found their way into lots of FNL skits. That part. And then of course, if surgical diagnosis is warranted for something like stage 3 or 4 endometriosis, then that is the third thing to ask about. And if you're not finding the answers that you are seeking from your primary care, from your OBGYN, please seek out a second opinion. Please seek out a specialist. Specialty consults are a covered benefit in the United States. They're a covered benefit state to state. If you don't know how to access your benefits, please reach out to navigators at medanswers.com. and we will help you. And as always, you can find Serena, me, and over 300 of our friends on the Fertility Answers app, all waiting to answer your questions. We'll see you next week. Thanks so much for tuning in.
Have a great day. Bye.
Bye.